Welcome to Traps, a new series. Every question here is built on one thing, two conditions that look alike until a single detail separates them. That detail is what the exam tests, and it is what most students miss. 50 questions, cardiology and pulmonology. Learn the discriminator, not the list. Which mechanism best explains her hypoxemia? A 24-year-old woman is found unresponsive after taking her roommate's oxycodone. Respirations are 6 per minute. Arterial blood gas on room air. PaO2 54 millimeters of mercury. PaO2 78 millimeters of mercury. The calculated alveolar arterial oxygen gradient is 11 millimeters of mercury. Read the command. The mechanism of hypoxemia. The A-a gradient is the discriminator. Normal gradient with a high PaO2 means the lung is fine and the drive is gone. A widened gradient means the gas exchange unit itself is broken. Every cause of hypoxemia falls on one side of the A-a gradient. A normal gradient means oxygen is crossing the alveolar membrane perfectly well. The problem is that not enough fresh air is arriving, or the inspired oxygen itself is low. That is H-hypoventilation, opioids, neuromuscular weakness, obesity hypoventilation, or high altitude. The tell is the rising PaO2 with the preserved gradient. A widened gradient means the lung is failing to oxygenate blood that reaches it, shunt, VQ mismatch, or a diffusion barrier. Because this patient's gradient is 11, normal for her age. Shunt, VQ mismatch, and diffusion impairment are all excluded. Choices A, B, and C wrong. The correct answer is E. The trap is answering from the PaO2 alone. A PaO2 of 54 is dramatic and pulls the eye toward lung pathology, but hypoxemia is a number, not a diagnosis. The gradient is what assigns the cause. Choice D is a distractor of a different kind. A shift in hemoglobin affinity changes how readily oxygen is released to tissue, not the arterial PaO2 measured by the blood gas. If you see normal A-a gradient with a high PaO2 leads to think hypoventilation, and look for the drug. Which finding does this extra sound indicate? A 62-year-old man with long-standing hypertension is evaluated for absorptional dyspnea. On auscultation, there is a low-frequency sound just before S1, best heard at the apex with the bell. The ventricle is not dilated. Read the command, what the extra harsh sound means. S3 and S4 are both low-frequency apical sounds heard with the bell, and students blur them. Timing separates them absolutely. The two extra harsh sounds sit on opposite ends of diastole. S4 comes LAT in diastole, immediately before S1, and it is the sound of the atrium contracting to push blood into a ventricle that has become stiff and non-compliant, classically from long-standing hypertension with concentric hypertrophy. S3 comes eerily in diastole, just after S2, and it is the sound of rapid passive filling into a dilated, volume-overloaded ventricle, dilated cardiomyopathy, advanced mitral or aortic regurgitation. Because this sound precedes S1 and the ventricle is explicitly not dilated, the early filling mechanism is excluded. Choice A wrong. The correct answer is B. One elegant consequence is worth carrying. Because S4 requires a coordinated atrial contraction, it cannot exist in atrial fibrillation. That single fact has decided many exam questions. Choice C describes a mid-systolic click, choice D a systolic ejection murmur, and choice E the mechanism of a widened S2 split, all systolic or S2 related events, and therefore wrong for a sound occurring in late diastole. If you see an S4 with hypertension leads to think stiff, hypertrophied ventricle, not a dilated one. Which statement about their ventricular remodeling is correct? Two patients are compared. Patient 1 has severe chronic aortic regurgitation. Patient 2 has severe chronic aortic stenosis. Both have normal ejection fractions. Read the command, the remodeling pattern in each lesion. Regurgitation and stenosis both overload the left ventricle, but with opposite kinds of load, and the muscle answers each differently. The ventricle remodels according to the type of load. Volume overload, aortic or mitral regurgitation, means the chamber must accommodate extra blood every beat, so sarcomeres are added IN series, the chamber lengthens, and the result is ECC-centric hypertrophy, a large dilated ventricle with a wall that is only modestly thickened. Pressure, overload, aortic stenosis or systemic hypertension, means the ventricle must generate a higher pressure, so sarcomeres are added IN parallel, and the result is concentric hypertrophy, a thick wall around a normal or small cavity. Assigning the wrong pattern to each lesion is what choices B and D do, and both invert the physiology. The correct answer is C. Choice E deserves attention because it is the most tempting form of wrong. A normal ejection fraction does not mean a normal ventricle. In aortic stenosis, the concentric ventricle can maintain a perfectly normal, even supernormal, ejection fraction while its diastolic filling is severely impaired. Remodeling precedes systolic failure by years, which is exactly why these patients present with dyspnea long before their ejection fraction falls. If you see a dilated ventricle with the regurgitant valve leads to think volume overload and sarcomeres in series. Which statement about this murmur is correct? An 18-year-old athlete has a harsh crescendo, decrescendo systolic murmur at the left sternal border. The murmur becomes louder when he stands up from squatting and softer with passive leg raise. Read the command. Which statement about this murmur is correct? Nearly every systolic murmur gets softer or preload falls. One gets louder, and that behavior alone names the lesion. Hypertrophic cardiomyopathy produces a dynamic obstruction, the hypertrophied septum, and the anterior mitral leaflet crowd, the outflow tract, and how much they obstruct depends on how full the ventricle is. Anything that reduces preload, standing, Valsalva strain, dehydration, shrinks the cavity, brings the obstructing surfaces closer, and makes the murmur louder. Anything that I and C graces preload or afterload, squatting, passive leg raise, hand grip, splits the outflow tract open and makes it softer. That is the inverse of every fixed lesion, so choices A, B, and E all state the relationship backwards. The correct answer is D. Choice C is the conceptual trap rather than a maneuver trap. Aortic stenosis is a fixed anatomic narrowing whose severity does not change beat to beat. Hypertrophic cardiomyopathy has a normal aortic valve and an obstruction that appears and disappears with loading conditions. That distinction also explains why these young patients collapse during exertion, when catecholamines and a falling preload conspire to maximize the gradient. If you see a systolic murmur that gets louder on standing, leads to think hypertrophic cardiomyopathy, not aortic stenosis. Which is the most likely diagnosis? A 6-year-old girl has a soft mid-systolic murmur at the upper left sternal border. The second heart sound is split, and the split does not change with inspiration or expiration. Read the command, the most likely diagnosis. The murmur here is almost decoration. The finding that decides the question is what the split does when the child breathes. Normal physiologic splitting widens on IN aspiration. Negative intrathoracic pressure pulls more blood into the right heart. Right ventricular ejection takes longer, and the pulmonic valve closes later. On expiration, the split narrows and may disappear. In an atrial septal defect, the two atria are in continuous communication, so the extra inspiratory venous return is shared between them rather than loading the right side alone. Right ventricular filling is therefore already chronically increased and no longer varies with the respiratory cycle. The split becomes fixed east. Because choice B requires the split to vary with breathing, the described finding excludes it. The correct answer is A. The murmur in an atrial septal defect is worth understanding because it misleads. It is not the sound of blood crossing the defect. That flow is low pressure and silent. It is a relative pulmonic stenosis murmur created because the increased right-sided volume must pass through a normal-sized pulmonic valve. Choice E would produce a wide split that still varies with respiration, and choices C and D produce whole systolic and continuous murmurs respectively, neither of which fixes the split. If you see a split S2 that ignores respiration leads to think atrial septal defect. Which statement best explains this response? A 58-year-old man has crushing chest pain. ECG shows ST elevation in leads 2, I3, and AVF. Blood pressure is 82 over 54 millimeters of mercury, and the lungs are clear. He is given sublingual nitroglycerin and becomes profoundly hypotensive. Read the command while the blood pressure collapses after nitroglycerin. The lead pattern names the artery names the territory of risk, and that territory explains the drug reaction. ST elevation in 2, I3, and AVF is an I inferior infarct, and in most people, the right coronary artery supplies that wall. The same artery supplies the right ventricle, so up to half of inferior infarcts involve it. A stunned right ventricle cannot generate its own stroke work. It functions as a passive conduit and depends entirely on filling pressure to push blood through to the left heart. That patient is preload dependent. Nitroglycerin is a venodilator whose whole purpose is to reduce preload. Giving it removes the only thing sustaining cardiac output, and the pressure collapses. The management is the opposite of the usual reflex: give FLUIDs and avoid nitrates and diuretics. The correct answer is D. The clear lungs are the detail that makes this recognizable, and choice E turns that same detail into a trap. Hypotension with clear lung fields is exactly what right ventricular failure looks like. The left ventricle is underfilled rather than overwhelmed, so there is nothing to back up into the pulmonary veins. Choice B would produce a new murmur and pulmonary edema, and choice C describes a phenomenon of coronary vasodilators such as dipyridamole, not nitroglycerin. If you see inferior ST elevation with hypotension after nitrates leads to think right ventricular infarction. Which process best explains the timing of this rupture? A 71-year-old man had an untreated anterior myocardial infarction 5 days ago. He suddenly becomes hypotensive with distended neck veins and muffled heart sounds and arrests. Autopsy shows blood in the pericardial sac. Read the command why the wall ruptured at this particular moment. Post-infarct complications are a timeline, and the timeline is a story about which cell is in the womb. The infarcted wall passes through a predictable sequence, and its mechanical strength follows it. In the first day, neutrophils arrive. From roughly day 3 to day 7, macrophages dominate. They phagocytose the necrotic myocytes and clear the debris. That clearance is necessary for healing, but it leaves the wall momentarily without either intact muscle or new collagen. Structurally at its weakest point, this is precisely when free. Wall rupture, papillary muscle rupture, and septal rupture cluster. Granulation tissue, and then a dense collagenous scar arrive over the following weeks, which is why choice D describes a much later stage and why rupture becomes rare after healing completes. The correct answer is B. The presentation confirms the mechanism. Blood filling the pericardial sac produces acute tamponade, hypotension, distended neck veins, and muffled heart sounds. Beck triad, followed rapidly by electromechanical dissociation. Choices A and C name real events but at the wrong point on the timeline. Neither corresponds to the period of maximum structural weakness, and neither explains a day 5 rupture. If you see sudden tamponade 3 to 7 days after an infarct leads to think free wall rupture during macrophage clearance. Which organism is most likely? A 29-year-old man who injects heroin has fever for 2 days and a new murmur that increases with inspiration. Echocardiography shows vegetations on a structurally normal tricuspid valve. Read the command, the most likely organism. Endocarditis splits cleanly into 2 diseases, and the tempo plus the state of the valve tells you which one you are looking at. ACUT endocarditis is caused by an organism virulent enough to seed and destroy a normal valve within days. Staphylococcus aureus is that organism, and in people who inject drugs, the venous return delivers it to the right heart first, which is why the tricuspid valve is involved and why these patients develop septic pulmonary emboli rather than systemic ones. Subacute endocarditis is the other disease. A low virulence viridans streptococcus such as Streptococcus sanguinis colonizes a valve. They are already damaged by rheumatic disease or a congenital lesion and smolders for weeks with fatigue and low-grade fever. The 2-day course on an undamaged valve excludes that picture. Choice A wrong. The correct answer is C. The inspiratory increase in the murmur is the physical sign that localizes the lesion to the right heart. Inspiration augments venous return and therefore augments right-sided flow and right-sided murmurs, a rule known as Carvalho sign. Choice D is the classic association with colonic neoplasia, and choice E a cause of culture, negative endocarditis in patients with animal exposure. Neither fits an acute tricuspid infection in this setting. If you see endocarditis on a normal valve within days, leads to think Staphylococcus aureus. Which pattern do these results represent? A 55-year-old woman with progressive dyspnea has pulmonary function testing. FBC is 62% of predicted. FEV1 is 64% of predicted. The FEV1 over FVC ratio is 0.82 and total lung capacity is 61% of predicted. Read the command. Which pattern the numbers represent? Students look at the following FEV1 and reach for obstruction. The ratio is what actually classifies the study. The FEV1 over FVC ratio classifies the disease. The absolute volumes tell you how severe it is. In OB obstruction, air leaves slowly, so FEV1 falls much further than FVC and the ratio drops below 0.7D. With air trapping, total lung capacity rises. In restriction, the lung cannot fill in the first place. FEV1 and FVC fall together, so the ratio is preserved or even elevated and total lung capacity falls. Here both volumes are down by a similar proportion. The ratio is a healthy 0.82 and total lung capacity is reduced, a textbook restrictive study. A reduced FEV1 alone, therefore, never establishes obstruction. Choices B and E wrong. The correct answer is A. The reduced total lung capacity is what makes choice D untenable. Submaximal effort can lower FVC, but it does not reduce a measured total lung capacity, which is obtained by body plethysmography or gas dilution rather than by forced expiration. Choice C would require the ratio to be reduced as well as the volumes, and this ratio is not merely normal, but toward the high end as stiff lungs recoil briskly. If you see, low volumes with a preserved ratio leads to think restriction and confirm with total lung capacity. Which statement about patient 2 is correct? 2 hypoxemic patients are placed on 100% inspired oxygen. Patient 1's PaO2 rises from 58 to 310 millimeters of mercury. Patient 2's PaO2 rises from 56 to only 71 millimeters of mercury. Read the command, what patient 2's response means. Both patients are hypoxemic and both receive the same intervention. The response to oxygen is the test that separates the two mechanisms. The oxygen challenge distinguishes shunt from VQ mismatch, and the distinction is mechanical. In VQ mismatch, blood still passes alveoli that are ventilated, just poorly. Raising the inspired oxygen concentration raises the alveolar oxygen in those units, and the PO2 corrects substantially, as in patient 1. In a true shunt, a fraction of the cardiac output passes through alveoli that are entirely unventilated, collapsed, consolidated, or filled with fluid, or bypasses the lung altogether through an intracardiac defect. That blood never meets oxygen at any inspired concentration, so it returns to the left heart desaturated no matter what the mass delivers, and the PaO2 barely moves. Choice C, wrong. The correct answer is E. Choices A and D fail on the same point. Hypoventilation is the one mechanism that responds beautifully to supplemental oxygen and leaves the AA gradient normal, the opposite of patient 2 on both counts. Choice B is a subtler distractor. A diffusion limitation does widen the gradient, but because it is a barrier rather than an absence of ventilation, raising the alveolar oxygen pressure increases the driving gradient across that barrier, and the PaO2 improves considerably. If you see hypoxemia that will not budge on 100% oxygen leads to think shunt and look for filled or collapsed alveoli, which is the most likely diagnosis. A 61-year-old man has headache, pruritus after hot showers, and a ruddy face. Hemoglobin is 19.4 grams per deciliter and the spleen is palpable. Serum erythropoietin is markedly LOW. Read the command, the most likely diagnosis. Every cause here raises the hematocrit. The erythropoietin level tells you whether the marrow is driving itself or being driven. The rule is a feedback loop. In primary polycythemia, polycythemia vera, driven by a JAK2 mutation, the marrow produces red cells autonomously without needing a signal. The expanded red cell mass then suppresses the kidney's erythropoietin production, so the EPO level is low. In every secondary polycythemia, the sequence runs the other way. Something raises EPO, chronic hypoxia from sleep apnea or altitude, or an EPO-secreting tumor, and the marrow obeys, so the EPO level is HH. A low EPO therefore excludes hypoxic and tumor-driven causes outright. Choices A, B, and E wrong. The correct answer is D. Two clinical details support the diagnosis independently of the laboratory value. Itching after a hot shower reflects histamine release from the expanded mast cell and basophil population, and splenomegaly reflects a myeloproliferative process. Neither occurs in secondary polycythemia, where the marrow is simply responding normally to a stimulus. Choice C fails on a different axis. Dehydration raises the hematocrit by shrinking plasma volume while the red cell mass stays normal, and it produces no splenomegaly. If you see a high hemoglobin with a low erythropoietin leads to think polycythemia vera. Which process explains this change? A 23-year-old woman with an unrepaired ventricular septal defect now has cyanosis and clubbing. Catheterization shows pulmonary artery pressure equal to systemic pressure, and the shunt now flows right to left. Read the command, what changed to reverse the shunt? A left to right shunt that turns blue has undergone one specific vascular transformation. A ventricular septal defect initially shunts LEFT to right because left-sided pressures are higher. That extra flow subjects the pulmonary arterioles to chronic high volume and shear stress, and they respond over years with medial hypertrophy, intimal fibrosis, and eventually irreversible obliterative changes. As pulmonary vascular resistance climbs to meet and then exceeds systemic resistance, the pressure gradient reverses and deoxygenated blood crosses into the systemic circulation. Eisenmenger syndrome, announced clinically by late cyanosis, clubbing, and polycythemia. Choice B would reduce the shunt and improve the patient rather than reverse the flow. The correct answer is E. The consequence that matters clinically is that this endpoint is a point of no return. Once the pulmonary vasculature is remodeled, surgically closing the defect removes the pressure relief pathway and precipitates acute right ventricular failure. So a shunt that was operable for years becomes inoperable, and transplantation becomes the only definitive option. Choice A would obstruct right ventricular outflow rather than raise pulmonary artery pressure to systemic levels, and choice C would worsen pulmonary congestion while leaving the shunt flowing left to right. If you see an old left to right shunt that becomes cyanotic leads to think Eisenmenger and do not close the defect. Which is the most likely diagnosis? A 14-year-old girl has blood pressure 58/96 millimeters of mercury in both arms and 104/62 millimeters of mercury in the legs. Femoral pulses are delayed relative to the radial pulses. A chest radiograph shows notching along the inferior margins of several ribs. Read the command, the most likely diagnosis. Hypertension in a teenager is always secondary until proven otherwise, and here the blood pressure difference between the arms and the legs localizes the lesion anatomically. A narrowing of the aorta distal to the left subclavian artery raises pressure in everything proximal to it and starves everything distal, producing exactly this upper body hypertension with diminished, delayed lower extremity pulses, a finding called radial femoral delay. Blood reaches the lower body through collaterals, and the most important of these run through the intercostal arteries. Over years, those enlarged pulsatile vessels erode the undersurface of the ribs, producing the RIB notching seen radiographically. That single radiographic sign is essentially specific and separates coarctation from every other cause of adolescent hypertension. Choices A and D wrong. The correct answer is C. Two associations should be reflexive. Coarctation is the classic cardiovascular lesion of Turner syndrome, and it accompanies a bicuspid aortic valve in a large minority of cases, which is why these patients also need surveillance for aortic dilation and early valve degeneration. Choice B can narrow the aorta and produce pulse deficits, but it does so with systemic inflammatory features and elevated inflammatory markers in a different demographic, and it does not generate the slowly built collateral circulation that notches ribs. If you see rib notching with an arm to leg pressure gradient leads to think coarctation and check for Turner syndrome. Which physiologic derangement is primarily responsible? A 47-year-old man with metastatic lung cancer has dyspnea and hypotension. Neck veins are distended, heart sounds are distant, and systolic pressure falls 18 millimeters of mercury during inspiration. Echocardiography shows a large pericardial effusion with right atrial collapse. Read the command, the primary derangement. Tamponade and cardiogenic shock, both present with hypotension and distended neck veins, so the mechanism, not the appearance, must be named. In tamponade, the myocardium is intact and contracting normally. The problem is entirely one of filling. Fluid under pressure in the pericardial sac compresses the thin-walled chambers during diastole, so the ventricles cannot receive an adequate volume, and stroke volume falls despite normal contractility. That is why the treatment is drainage rather than inotropes, and why choice B misnames the lesion. The findings follow directly: distended neck veins because venous return cannot enter, muffled sounds because fluid insulates, and hypotension because stroke volume is limited. The correct answer is A. Pulsus paradoxus deserves this mechanism because it recurs across the exam. Within a rigid, fluid-filled pericardium, the two ventricles share a fixed total volume, so they become interdependent. On inspiration, the augmented venous return expands the right ventricle, the septum bows leftward, and left ventricular filling and output fall, dropping systolic pressure by more than 10 millimeters of mercury. The same physiology appears in severe asthma from wide swings in intrathoracic pressure. Choices C and D would each produce a characteristic murmur, and neither explains right atrial collapse on echocardiography. If you see hypotension with distended neck veins and a quiet precordium leads to think tamponade and drain it. Which statement about their radiographic findings is correct? 2 retired workers are compared. Worker 1 spent 30 years sandblasting. Worker 2 spent 30 years removing pipe insulation from ships. Read the command. Which radiographic statement is correct? The pneumoconioses are separated by 2 things: the zone of the lung involved and whether the pleura is affected. Particle size determines where the dust lands, and that dictates the radiographic zone. Silica and cold dust particles deposit in the Upper zones, producing upper lobe nodular opacities. Silicosis adds the characteristic EGG shell calcification of hilar lymph nodes. Asbestos fibers are long and thin, travel further with airflow, and deposit in the lower zones, producing basal interstitial fibrosis. And asbestos alone reaches and irritates the pleura, generating the pleural plaques that are its signature and the mesothelioma risk that makes it feared. Choice C assigns the pleural findings to the sandblaster, and choice D assigns the eggshell nodes to the asbestos worker. Both invert the pairing. The correct answer is B. Choice E is wrong for a mechanistic reason worth remembering. Silica is directly toxic to alveolar, macroph, phages, and because macrophages contain mycobacteria within granulomas, silicosis carries a markedly increased risk of tuberculosis. A favorite second-order question. One further pairing is frequently confused. In asbestos exposure, bronchogenic carcinoma is a more common malignancy than mesothelioma, even though mesothelioma is the more specific association, and smoking multiplies that lung cancer risk dramatically. If you see lower zone fibrosis with pleural plaques leads to think asbestos, and remember lung cancer outnumbers mesothelioma. Which is the most likely poisoning? A 34-year-old man is rescued from an industrial fire. He is confused. PaO2 is 96 millimeters of mercury on room air, and pulse oximetry reads 98%. Lactate is 11 millimoles per liter, and the measured venous oxygen saturation is unusually HIGH at 88%. Read the command. Which poisoning? Several fire-related toxins give a normal PaO2. The venous oxygen saturation is the discriminator, because it reports whether tissues are extracting oxygen at all. Cyanide binds cytochrome C oxidase, complex IV of the electron transport chain, and halts oxidative phosphorylation. Oxygen is delivered normally, so the PaO2 and the arterial saturation are normal, but the tissues cannot consume it. The unextracted oxygen returns to the right heart, and the venous oxygen saturation rises, sometimes to arterial levels, a phenomenon called arterialization of venous blood. Cells forced onto anaerobic glycolysis generate the profound LACT-ICI doses seen here. This is histo-oxy-C hypoxia, in which the defect is utilization rather than delivery. The correct answer is A. Carbon monoxide is the co-exposure in the same fire and the most tempting alternative, but it fails on the venous saturation. Carbon monoxide binds hemoglobin with high affinity, so oxygen content falls even though the dissolved PaO2 is normal, and it left shifts the dissociation curve, so the remaining oxygen is released reluctantly. Venous saturation therefore falls rather than rises. It also fools standard pulse oximetry, which cannot distinguish carboxyhemoglobin from oxyhemoglobin, which is why the reading here is uninformative. Choice C produces cyanosis with a characteristic saturation gap, and choices D and E do not raise venous oxygen saturation. If you see, lactic acidosis with a high venous oxygen saturation leads to think cyanide. Which change in oxygen hemoglobin dissociation curve occurs, and what is its consequence? During strenuous exercise, blood traversing a skeletal muscle capillary encounters a local temperature of 39.5 degrees C, a pH of 7.4, and a PCO2 of 58 millimeters of mercury. Read the command, the direction of the shift, and what it accomplishes. Two things must both be right: which way the curve moves, and what moving that way does. A right shift means hemoglobin holds oxygen, LESS tightly. Affinity falls and oxygen is unloaded more readily to the tissue. The factors that cause it are the signature of metabolically active tissue, increased CO2, increased hydrogen ion of falling pH, increased temperature, and increased 2003 BPG, remembered as CADIT, face right. Exercising muscle generates every one of them, which is precisely the point. The tissue working hardest chemically instructs hemoglobin to release more oxygen exactly where it is needed. This coupling of CO2 and hydrogen ion to oxygen release is the BOHR effect. The correct answer is B. Choices C and D are the instructive errors because each gets the direction right and the meaning wrong. A right shift decreases affinity, and a left shift increases it. Pairing the two halves correctly is the whole skill. The mirror image is worth holding alongside. Fetal hemoglobin lacks the beta chains that bind 2003 BPG, so it sits left shifted and holds oxygen more tightly, which is exactly how it strips oxygen from maternal blood across the placenta. If you see hot acidotic CO2-rich tissue leads to think right shift and greater oxygen delivery. What is the purpose of this pulmonary response? A segment of lung is obstructed by a mucus plug, and alveolar oxygen tension in that segment falls. The arterioles supplying it constricts. In a systemic tissue bed, the same fall in local oxygen tension produces the opposite arteriolar response. Read the command. The purpose of the pulmonary response. The lung is the one vascular bed that does the opposite of everywhere else, and the reason is worth understanding rather than memorizing. Systemic arterioles dilate in response to local hypoxia because their job is to deliver more blood to a tissue that is short of oxygen. The lung has no such job. Its blood is passing through to be oxygenated, not to feed the lung. So the pulmonary vasculature does the reverse. Hypoxic pulmonary vasoconstriction shunts blood away from poorly ventilated alveoli and toward well-ventilated ones, preserving ventilation perfusion matching and keeping arterial oxygenation as high as possible. Sending more blood to an unventilated segment, as choices A and E imagine, would simply create a shunt and worsen hypoxemia. The correct answer is D. Choice C inverts the consequence. When hypoxia is local, the response is helpful. When it is GL-lobal, advanced COPD, sleep apnea, or life at altitude, every pulmonary arteriole constricts at once, pulmonary vascular resistance rises rather than falls, and sustained pulmonary hypertension leads to right ventricular hypertrophy and cor pulmonale. The same mechanism has an elegant fetal role. The unventilated fetal lung is profoundly vasoconstricted, which is exactly what keeps blood flowing through the ductus arteriosus until the first breath opens the pulmonary bed. If you see arterioles constricting in response to hypoxia leads to thin lung, not systemic tissue. Which tumor is most likely? A 66-year-old smoker has a central lung mass. Serum calcium is 13.1 milligrams per deciliter. Phosphate is low, and parathyroid hormone is suppressed. Parathyroid hormone-related peptide is elevated. Bone scan shows no metastases. Read the command, which tumor? The lung paraneoplastic syndromes are a small fixed set, and each belongs to a specific histology. Getting the pairing backwards is the standard error. Hypocalcemia in lung cancer arises two ways, and the laboratory pattern distinguishes them. Here it is humoral. The tumor secretes parathyroid hormone-related peptide, which acts on the parathyroid hormone receptor to raise calcium and lower phosphate, while true parathyroid hormone is appropriately suppressed by the feedback loop. That mechanism belongs to squamous cell carcinoma, which is also central and strongly smoking associated. The alternative mechanism, direct osteolysis from bone metastases, is excluded by the negative bone scan. The correct answer is E. Choice A is the near miss that punishes imprecise memory. Small cell carcinoma is also central and also smoking related, but its paraneoplastic repertoire is endocrine in a different direction. SIADH producing hyponatremia, ectopic ACTH producing Cushing syndrome, and Lambert-Eaton myasthenic syndrome from antibodies against presynaptic calcium channels. A useful shorthand is that squamous cancer disturbs calcium while small cell disturbs sodium and cortisol. Choices B and D are peripheral tumors without this humoral signature. If you see hypercalcemia with elevated PTA3P and a central lung mass leads to think squamous cell carcinoma. Which statement about this disease is correct? A 41-year-old man who has never smoked has progressive dystonia. Imaging shows emphysema most severe at the lung, basis. Liver enzymes are elevated, and liver biopsy shows periodic acid, shift positive, diastase-resistant globules, and hepatocytes. Read the command, which statement about the disease is correct. Alpha-1 antitrypsin deficiency injures two organs by two opposite mechanisms, and the exam tests whether you can hold both at once. Alpha-1 antitrypsin is made in the liver and exported to inhibit neutrophil elastase in the lung. The mutant protein misfolds, and that single defect produces two different diseases. In the LU, the problem is deficiency. 2-liter antiprotease arrives. Elastase runs unopposed, alveolar walls are digested, and panacinar emphysema develops, characteristically at the basis and in people who never smoked. In the liver, the problem is the opposite, retention. The misfolded protein accumulates inside hepatocytes as PAS, positive diastase-resistant globules, causing hepatitis and cirrhosis. Choices A, B, and E each collapse the two mechanisms into one. The correct answer is C. The distribution of emphysema is itself a discriminator and makes choice D wrong. Smoking-related emphysema is centriacinar and predominates in the upper lobes. Alpha-1 antitrypsin deficiency is panacinar and predominates at the basis. When a young non-smoker presents with basilar emphysema, that pattern alone should prompt the diagnosis. Smoking does not cause this disease but accelerates it severely because cigarette smoke oxidatively inactivates whatever functional antitrypsin remains. If you see basilar emphysema in a young non-smoker with liver disease leads to think alpha-1 antitrypsin deficiency. Which acid-base disturbance is present? A 19-year-old woman ingests an unknown quantity of aspirin. She has tinnitus, fever, and rapid deep breathing. Arterial blood gas, pH 744, PaCO2, HCO3 HCO3, 12 milliequivalents per liter. The anion gap is 24. Read the command, the acid-base disturbance. A near normal pH is the most dangerous finding on this gas because it looks like nothing is wrong. Salicylate does two independent things. It stimulates the medullary respiratory center directly, driving hyperventilation and a primary respiratory alkalosis, and it uncouples oxidative phosphorylation and generates organic acids, producing a primary anion, gap metabolic acidosis. Both are primary disturbances, not compensations for one another, which is why the pH can sit deceptively near normal while the patient is critically ill. The signature is that BOTH2 and the bicarbonate are markedly low simultaneously, with a raised anion gap. The correct answer is E. The distinction from a compensated single disorder is the point, and it is testable. Compensation never fully normalizes the pH and never overshoots. When the pH is normal, while both the respiratory and metabolic parameters are deranged in opposite directions, a mixed disorder is present by definition. Choice B fails a further check. Pure metabolic acidosis with appropriate respiratory compensation would predict a PaCO2 near 25 by Winter formula, not 18. Alkalinizing the urine with bicarbonate ion traps salicylate and accelerates its elimination. If you see a normal pH with a low PaSO2 and a low bicarbonate leads to think mixed disorder and think salicylate. Which cardiomyopathy pattern and dysfunction does this represent? A 54-year-old man with a history of heavy alcohol use has orthopnea. Echocardiography shows a dilated left ventricle with an ejection fraction of 24% and a globally thin wall. Read the command, the pattern, and the type of dysfunction. 3 cardiomyopathies, and the exam wants both halves of the pairing. The 3 cardiomyopathies split by geometry and by which phase of the cardiac cycle fails. Dilated is the only one that is primarily systolic. The chamber enlarges, the wall thins, contractility falls, and the ejection fraction drops. As here, with alcohol among its classic causes alongside viral myocarditis, doxorubicin, peripartum cardiomyopathy, and thiamine deficiency. Hypertrophic and restrictive are both primarily diastolic. The ventricle cannot relax and fill properly, but contractility and therefore ejection fraction remain normal or even high. An ejection fraction of 24% is incompatible with either. Choices B, C, D, and E wrong. The correct answer is A. Holding the pairing this way prevents a common downstream error, because 2 of the 3 cardiomyopathies preserve the ejection fraction. A normal ejection fraction never excludes severe heart failure. The patient with restrictive or hypertrophic disease is breathless because filling pressures are high, not because ejection is poor. Choice E names a genuine cause of restrictive disease, but amyloid produces a non-dilated ventricle with thickened walls and a preserved ejection fraction, the opposite of this echocardiogram. If you see a dilated ventricle with a low ejection fraction, leads to think systolic failure. If the ejection fraction is preserved, think diastolic. Which statement best explains her symptoms? A 28-year-old woman with heavy menstrual bleeding has fatigue and exertional dyspnea. Hemoglobin is 6.2 grams per deciliter. Arterial blood gas on room air shows PaO2 98 millimeters of mercury with an oxygen saturation of 99%. Read the command. What explains her symptoms? The blood gas is perfect and the patient is symptomatic, which means the blood gas is not measuring the thing that is wrong. A blood gas reports oxygen. Tension, the pressure of oxygen dissolved in plasma, and the saturation of whatever hemoglobin is present. Neither measures how much oxygen the blood actually carries. Oxygen content is dominated by hemoglobin concentration because the great majority of oxygen travels bound to hemoglobin rather than dissolved. With a hemoglobin of 6.2, this patient carries roughly half the normal oxygen per unit of blood, even though every molecule of her hemoglobin is fully saturated and her PaO2 is entirely normal. That is anemic hypoxia, and choices A and D both misread a normal gas as abnormal. The correct answer is B. The conceptual error this question targets is treating saturation as a measure of quantity. Saturation answers what proportion of available binding sites are occupied. If there are few sites, a 99% saturation is still a small absolute amount of oxygen. The same reasoning explains carbon monoxide poisoning, where functional hemoglobin is reduced although PaO2 is normal. Choice C describes a left shift, which impairs unloading rather than carriage, and choice E describes cyanide, which would raise venous saturation and produce lactic acidosis rather than a slow anemia. If you see a normal blood gas in a breathless, anemic patient, leads to think oxygen content, not oxygen tension. Which is the most likely diagnosis? A 48-year-old man has fever, weight loss, abdominal pain after meals, new foot drop, and hypertension. Serology for hepatitis. B surface antigen is positive. Anti-neutrophil cytoplasmic antibodies are negative. Chest imaging is normal. Angiography shows microaneurysms of the mesenteric arteries. Read the command, the most likely diagnosis. Two features here do the discriminating, and both are negatives. The lungs are clear and the ANSI is absent. Polyarteritis nodosa is a medium vessel necrotizing vasculitis with three discriminating features. It spares the lungs, it is ANCA negative, and it is associated with hepatitis. B. Transmural inflammation weakens the arterial wall and produces the string of beads, microneurisems seen on angiography, while involvement of the vasa nervorum produces mononeuritis. Multiplex Harris Poinco. Renal artery involvement drives the hypertension. The small vessel ANCA-associated vasculitides do the opposite on both counts. They are ANCA positive and they characteristically attack the lung. Choices A, B, and C wrong. The correct answer is D. The lung is the single most efficient discriminator in this group. Granulomatosis with polyangiitis produces the triad of upper airway disease, lung nodules or cavities, and glomerulonephritis with C, ANCA against proteinase 3. Microscopic polyangiitis gives pulmonary renal disease with P and C against myeloperoxidase, but no granulomas. Eosinophilic granulomatosis with polyangiitis is preceded by asthma with marked eosinophilic granulomatosis with polyangiitis is preceded by asthma with marked eosinophilia. Choice E affects large vessels in an older population with headache and jaw claudication and does not produce mesenteric microaneurysms. If you see a systemic vasculitis with clear lungs and negative ANCA leads to think polyarteritis nodosa, and check hepatitis B. Which complication most threatens him if untreated? A 3-year-old boy has fever for 6 days, bilateral non-exudative conjunctival injection, a strawberry tongue with cracked lips, a polymorphous truncal rash, erythema of the palms and soles, and one enlarged cervical node. Read the command, the complication that threatens him. The clinical picture is a checklist, and the reason to recognize it quickly is one specific arterial consequence. This is Kawasaki disease, a medium vessel vasculitis of young children, and the features are remembered as fever plus crash, conjunctivitis, rash, adenopathy, strawberry tongue, and hands and feet changes. Its importance is entirely cardiac. The inflammation has a predilection for the coronary arteries, and untreated it produces coronary artery aneurysm S in a substantial minority of children, with subsequent thrombosis, myocardial infarction, and sudden death. Prompt: intravenous immunoglobulin plus aspirin dramatically reduces that risk, which is why this is one of the few pediatric diagnoses that must be made on clinical criteria without waiting. The correct answer is C. Aspirin here is worth a note because it contradicts a rule students hold firmly. Aspirin is generally avoided in children because of Reye syndrome, yet Kawasaki disease is a deliberate exception since the thrombotic risk from coronary aneurysms outweighs that concern. Choices A and B are both post-streptococcal sequelae with different mechanisms and timelines, and choice D belongs to connective tissue disorders and tertiary syphilis rather than to a febrile toddler. If you see 5 days of fever with conjunctivitis and a strawberry tongue leads to think Kawasaki and protect the coronaries. What is the best next step? A 74-year-old woman has a new temporal headache, pain in the jaw while chewing, and transient loss of vision in one eye. Erythrocyte sedimentation rate is 88 millimeters or H. Temporal artery biopsy is scheduled for the following week. Read the command, the best next step. This is a questionable sequence, and the sequence here inverts the usual instinct to confirm before treating. Giant cell arteritis threatens the ophthalmic artery, and the visual loss it causes is sudden, painless, and irreversible. Transient monocular visual loss is the warning shot before permanent blindness, sometimes within hours. Corticosteroids must therefore be started immediately on clinical suspicion before any confirmatory test. The biopsy is not compromised by this. The inflammatory infiltrate remains detectable for 1 to 2 weeks after steroids begin, so treating first costs nothing diagnostically and may save the eye. Waiting for confirmation, as choice A proposes, is the error the question is built to punish. The correct answer is D. Jaw claudication is the most specific symptom in the presentation and should trigger the reflex on its own. 2 further points recur. The biopsy has skipped lesions, so a long segment is needed, and a negative result does not exclude the diagnosis in a convincing clinical picture. And roughly half of these patients have polymyalgia rheumatica, with proximal shoulder and hip girdle pain and stiffness. Choices B, C, and E all delay definitive therapy, while the ophthalmic artery remains at risk. If you see jaw claudication with the raised sedimentation rate leads to think giant cell arteritis and give steroids before the biopsy. Which mechanism best explains the reduced ventilatory drive? A patient with severe COPD who chronically retains carbon dioxide is given high-flow oxygen. Over the next hour, his respiratory rate falls and his PaCO2 rises further. Read the command, the mechanism of the reduced drive. 2 chemoreceptor populations exist. They sense different things, and only one of them is still doing useful work in this patient. Central chemoreceptors in the medulla sense hydrogen ion concentration in cerebrospinal fluid driven by CO2 crossing the blood-brain barrier, and they normally supply the great majority of ventilatory drive. In a chronic retainer, cerebrospinal fluid bicarbonate rises over time to buffer that acidity, and the central receptors adapt. They stop responding to a chronically high CO2. What remains is the peripheral drive from the carotid and aortic bodies, which sense LOW oxygen. Flooding the patient with oxygen abolishes precisely that stimulus, ventilation falls, and CO2 climbs further. Choice B names the receptor that has already been silenced by adaptation. The correct answer is A. The clinical rule that follows is one of measured caution, not refusal. Oxygen is never withheld from a hypoxemic patient. Hypoxia kills faster than hypercapnia, but it is titrated to a target saturation of roughly 88 to 92% rather than driven to 100%. Worth noting alongside, a component of the CO2 rise also comes from released hypoxic pulmonary vasoconstriction, worsening VQ matching, and from the Haldane effect. Choices C, D, and E describe mechanisms that do not operate at therapeutic oxygen concentrations. If you see a CO2 retainer who slows down on high-flow oxygen, leads to think loss of the hypoxic drive. Which effect is described, and where does its counterpart operate? In a pulmonary capillary, hemoglobin binds oxygen. As it does so, its affinity for carbon dioxide and hydrogen ion decreases, promoting their release into the alveolus. Read the command, which effect and where its counterpart acts. Bohr and Haldane are 2 halves of the same partnership and are constantly swapped by students. The Haldane effect describes oxygenation controlling carbon dioxide carriage. When hemoglobin binds oxygen in the lung, it becomes a weaker carrier of carbon dioxide and a weaker buffer of hydrogen ion, so both are unloaded for exhalation. The BOHR effect is the mirror image and operates in peripheral tissue. Rising carbon dioxide and hydrogen ion reduce hemoglobin's affinity for oxygen, right shifting the curve, so oxygen is released where metabolism is highest. So, the effect described is Haldane, and its counterpart, Bohr, works in the tissues, which makes choices A and C wrong on the naming, and choice B wrong on the location. The correct answer is E. A clean way to keep them apart is to name what the controlling variable is. In the Haldane effect, oxygen is in charge and carbon dioxide responds. In the Bohr effect, carbon dioxide and acid are in charge and oxygen responds. The pairing has a clinical consequence. Giving oxygen to a carbon dioxide retainer raises PaCO2 partly through the Haldane effect, because newly oxygenated hemoglobin releases carbon dioxide it was carrying. Choice D names a genuine and related process. Bicarbonate leaving the red cell in exchange for chloride. But that is about carbon dioxide transport chemistry, not about affinity coupling. If you see oxygen binding that pushes carbon dioxide off hemoglobin leads to think Haldane in the lung. Why did the initial antibiotic fail? A 20-year-old college student has 3 weeks of dry cough, low-grade fever, and malaise, and looks far better than his chest radiograph suggests, which shows diffuse interstitial infiltrates. He was treated with amoxicillin without improvement. Cold agglutinins are positive. Read the command. Why the antibiotic failed? The organism is guessable from the syndrome, but the question asks for the structural reason. A whole drug class is useless against it. Mycoplasma pneumoniae has no cell wall. Beta-lactams, penicillins, and cephalosporins work exclusively by inhibiting the cross-linking of peptidoglycan in the bacterial cell wall, so an organism without one is intrinsically immune to the entire class, no resistance mechanism required. This is why amoxicillin failed and why treatment must use a macrolide or a tetracycline, which act on the ribosome instead. Choices A and E both describe acquired resistance mechanisms, which imply a target that exists and has been modified. Here, the target was never present. The correct answer is B. Cold agglutinins are the laboratory signature and can be clinically significant, producing an IgM-mediated hemolytic anemia that agglutinates in cooler peripheral blood. The discrepancy between a well-apparent patient and an alarming film is the other classic tell, and it is what earned the name walking pneumonia. Choice C is tempting because the syndrome resembles a viral illness, but cold agglutinins and the response to a macrolide both point to an atypical bacterium. If you see pneumonia unresponsive to a beta-lactam with cold agglutinins leads to think mycoplasma and no cell wall. Which hypersensitivity mechanisms are involved? 2 children develop illness after untreated streptococcal pharyngitis. Child 1 develops migratory polyarthritis, carditis, and chorea 3 weeks later. Child 2 develops cola-colored urine, periorbital edema, and hypertension 2 weeks later. Read the command. The hypersensitivity mechanism in each. The same organism causes both sequelae by 2 different immunologic routes, and the pairing is routinely inverted. Rheumatic fever is a TY2, hypersensitivity driven by molecular mimicry. Antibodies raised against the streptococcal M protein cross react with structurally similar antigens in cardiac myosin, valve tissue, joints, and basal ganglia, binding directly to those host tissues and directing damage against them. Post. Streptococcus glomerule. Nephritis is a type 3 reaction. Circulating antigen-antibody complexes deposit in the glomerular basement membrane, activating complement and producing the lumpy, bumpy immunofluorescence and subepithelial humps on electron microscopy. Both would be conflated by choice A and reversed by choice B. The correct answer is C. One consequence separates them clinically and is frequently tested. Treating the pharyngitis with antibiotics prevents rheumatic fever because it eliminates the antigenic stimulus before mimicking antibodies mature, but it does not reliably prevent post-streptococcal glomerulonephritis. Rheumatic fever is also the one that recurs with each new streptococcal infection, which is why these children receive long-term prophylaxis. Choices D and E name mechanisms with the wrong effectors and the wrong timing for either illness. If you see, a post-streptococcal complication leads to decide first whether antibody binds tissue or complexes deposit. What is the most appropriate immediate treatment? A 22-year-old man is brought in after ingesting his father's amitriptyline. He is confused with dry flushed skin and dilated pupils. ECG shows a QRS duration of 138 misses and a terminal R wave in AVR. Read the command, the immediate treatment. The anticholinergic features are noisy and memorable. The finding that will kill him is the width of the QRS. Tricyclic antidepressants have several toxicities, but the lethal one is blockade of cardiac fast sodium channels that slows phase 0 depolarization, widens the QRS, and predisposes to ventricular arrhythmias and refractory hypotension. A widening QRS is the single best predictor of seizures and arrhythmia. Sodium bicarbonate treats it on two fronts. The sodium load overcomes the channel blockade by mass action, and alkalinization reduces drug binding to the channel. It is given to narrow the QRS, not to correct pH. The correct answer is A. Choice C is the trap that looks clever. Physostigmine reverses anticholinergic delirium, and this patient is certainly anticholinergic. But in tricyclic overdose, it can precipitate asystole and seizures, and it is contraindicated. Treating the visible syndrome instead of the lethal one is exactly the error. It is also worth remembering that class IA and IC antiarrhythmics are themselves sodium channel blockers and would compound the toxicity, so the instinct to treat a wide complex rhythm with an antiarrhythmic must be suppressed here. If you see a widening QRS after an overdose leads to think sodium channel blockade and give bicarbonate. Which statement about her heart failure is correct? A 78-year-old woman with long-standing hypertension has orthopnea and bilateral crackles. Echocardiography shows an ejection fraction of 62%, a thick-walled left ventricle with a small cavity, and impaired relaxation on tissue Doppler. Read the command. Which statement is correct? A patient in obvious pulmonary edema with a normal ejection fraction forces the distinction the exam wants. Heart failure means the heart cannot meet demand at acceptable filling pressures, and that can happen in two ways. Systolic failure, heart failure with reduced ejection fraction, means the ventricle cannot eject, contractility falls, the chamber dilates, the ejection fraction drops. Diastolic failure, heart failure with preserved ejection fraction, means the ventricle cannot fill. Chronic hypertension produces a stiff, concentrically hypertrophied ventricle that requires high pressures to accept blood, and those pressures transmit back to the lungs. Contractility is normal, so choices B and E misname the defect, and the ejection fraction being normal never excludes failure. Choice are wrong. The correct answer is C. Why the symptoms are indistinguishable is worth grasping, because it explains why echocardiography rather than examination makes this call. In both forms, the left atrial and pulmonary venous pressures rise, so both produce orthopnea, crackles, and edema at the bedside. The distinction matters therapeutically. The drugs that improve survival in reduced ejection fraction have not shown the same benefit in preserved ejection fraction, where treatment centers on controlling blood pressure, rate, and volume. Choice D would show a high cardiac output with a wide pulse pressure, not a thick-walled ventricle. If you see congestion with a preserved ejection fraction, leads to think diastolic failure from a stiff ventricle. At which vertebral level does this opening lie? During a repair of a hiatal hernia, a surgeon identifies the diaphragmatic opening that transmits the esophagus and the vagal trunks. Read the command the vertebral level of the esophageal opening. Three structures cross the diaphragm at three levels, and the mnemonic exists because the levels are otherwise indistinguishable. The diaphragm has three principal openings, and their levels follow the numbers 8, 10, and 12. The inferior vena cava passes at T8, accompanied by the right phrenic nerve. The esophagus passes at T10, accompanied by the anterior and posterior vagal trunks. And the count of letters is a useful check since esophagus and vagus each carry 10. The aorta passes at T12, behind the diaphragm rather than through it, accompanied by the thoracic duct and the azygos vein. The traditional mnemonic runs, I ate 10 eggs at 12. The correct answer is D. The anatomic detail with functional weight is that the aortic opening lies posterior to the diaphragm rather than within its muscular part. Because of that, diaphragmatic contraction does not compress the aorta, and aortic flow is not modulated by the respiratory cycle, unlike the inferior vena cava, whose opening in the central tendon is pulled open during inspiration, augmenting venous return. The esophageal hiatus is formed by the right crus, whose fibers act as a physiologic sphincter. Laxity there is what permits a hiatus hernia. If you see A structure crossing the diaphragm leads to place it at T8, T10, or T12 before naming it. Which statement about monitoring these drugs is correct? A patient with a pulmonary embolism is started on unfractionated heparin and warfarin simultaneously. On day 2, the activated partial thromboplastin time is therapeutic and the international normalized ratio has begun to rise. Read the command, which monitoring statement is correct? 2 anticoagulants, 2 pathways, 2 tests, and mixing up which belongs to which is one of the most common pharmacology errors. Heparin potentiates antithrombin, inhibiting thrombin and factor XA, and its effect registers on the intrinsic pathway, monitored by the acetated partial thromboplastin time. Warfarin inhibits vitamin K epoxide reductase, depleting factors E, 7IX, and X, and because factor 7 has the shortest half-life, the E extrinsic pathway is affected first, monitored by the prothrombin time and the INR. Assigning each test to the wrong drug is what choices B and D do. Choice A ignores the intrinsic pathway entirely. The correct answer is E. The reason the two are started together is itself a testable mechanism. Warfarin also depletes proteins C and S, which are natural anticoagulants with short half-lives, so in the first days it produces a transient procoagulant state, the cause of warfarin-induced skin necrosis. Overlapping with heparin covers that window. Choice C is unsafe for both drugs, though it would be correct for the direct oral anticoagulants, which have predictable pharmacokinetics and need no routine monitoring. If you see anticoagulant monitoring leads to trace the drug to its pathway, then to its test. Why is this drug a poor choice here? A 31-year-old man has crushing chest pain 1 hour after using cocaine. Heart rate is 108 per minute, and blood pressure is 160 over 104 millimeters of mercury. A resident proposes intravenous metoprolol. Read the command, why the beta blocker is a poor choice. Cocaine stimulates both adrenergic receptor families, and blocking only one of them has a predictable consequence. Cocaine blocks catecholamine reuptake, so both alpha and beta receptors are stimulated. Beta stimulation raises heart rate and contractility. Alpha stimulation constricts vessels, including the coronary arteries. Giving a selective beta blocker removes the beta-mediated vasodilatory and chronotropic effects while leaving alpha-mediated vasoconstriction entirely unopposed. Coronary vasoconstriction worsens in blood pressure. The appropriate agents are benzodiazepines, which reduce central sympathetic outflow, together with nitrates and calcium channel blockers. The correct answer is B. The same unopposed alpha logic recurs in one other classic setting worth pairing with this one. A patient with piochmocytoma must be alpha blocked with phenoxybenzamine before any beta blocker is introduced, for exactly the same reason. Choices A, C, and D describe effects that are either minor or physiologically incorrect in this context, and choice E is not the recognized interaction. If you see an adrenergic crisis needs to block alpha before beta, or block neither. Which pairing is correct? 2 anti-anginal drugs are compared. Drug 1 markedly reduces end diastolic volume with little change in heart rate. Drug 2 reduces heart rate and contractility with little change in venous capacitance. Read the command, which pairing is correct. Angina therapy is a 2-lever system, and each drug pulls a different lever. Nitrates are predominantly venodilators. By expanding venous capacitance, they reduce venous return, which lowers end diastolic volume, preload, and therefore wall stress and myocardial oxygen demand. That is drug 1. Beta blockers act on the heart itself, reducing heart rate and contractility. The two are the major determinants of oxygen demand, with little direct effect on venous capacitance. That is drug 2, reversing them, as choice B does, misassigns the entire mechanism of both classes. The correct answer is A. Choice D touches something real and worth stating precisely. Nitrates alone do cause a reflex tachycardia as baroreceptors respond to the fall in filling, which partially offsets their benefit and is one reason a beta blocker is added rather than either being used alone. The pairing is complementary in a second way because the coronary arteries fill during diastole. Slowing the heart lengthens diastole and improves myocardial perfusion, addressing supply while the nitrate addresses demand. If you see, an antiagonal question leads to ask whether the drug changes preload or changes rate and contractility. What is the most appropriate next step? A 44-year-old woman returns from a long flight with pleuritic chest pain and dyspnea. She has no tachycardia, no leg swelling, no hemoptysis, no malignancy, and no prior thromboembolism. Clinical assessment places her at LOW pretest probability. Read the command, the next step. The pretest probability is stated explicitly, and that word changes which test is correct. B. Dimer is highly sensitive, but poorly specific. It rises in infection, malignancy, pregnancy, surgery, and age. A sensitive test is useful for RULing out, and only when the pretest probability is already low. In that setting, a negative D-dimer drives the post-test probability low enough to exclude pulmonary embolism without imaging, sparing contrast and radiation. If the pretest probability were hitched, the D-dimer would be the wrong test entirely, because a negative result could not overcome the prior probability and CT pulmonary angiography would be indicated directly, as choice A proposes. The correct answer is C. The principle generalizes well beyond this diagnosis, and the exam tested repeatedly under different clinical costumes. The value of a test depends on the probability you had before ordering it. Choice D is reserved for patients in whom iodinated contrast must be avoided, such as significant renal impairment or contrast allergy. Choice E can support the diagnosis if positive, but a negative leg ultrasound does not exclude pulmonary embolism since the clot may have embolized completely. If you see, a diagnostic strategy question leads to establish the pretest probability before choosing the test. Which statement about surfactant in these two patients is correct? Two patients have diffuse alveolar collapse with stiff lungs. Patient 1 is an infant born at 29 weeks. Patient 2 is an adult with severe pancreatitis and bilateral infiltrates with a normal cardiac silhouette. Read the command, the statement about surfactant in each. Both lungs are stiff and both collapse, but the surfactant is failing for opposite reasons. In neonatal respiratory distress syndrome, the type 2 pneumocytes are immature and have not yet begun adequate surfactant synthesis, which typically becomes sufficient around 35 weeks. The deficiency is one of production, which is why antenatal corticosteroids, accelerating maturation, are the preventive strategy. In ARDS, the type 2 pneumocytes are present and functional. The alveolar fluid with protein-rich exudate that ion activates the surfactant already there, and the diffuse alveolar damage with hyaline membranes follows. Choices A and B each apply one mechanism to both patients. The correct answer is E. The normal cardiac silhouette is the detail that separates ARDS from cardiogenic pulmonary edema, which produces an identical clinical picture of hypoxemia with bilateral infiltrates. That distinction determines management completely. ARDS is treated with low tidal volume ventilation to limit further injury, while cardiogenic edema is treated by unloading the failing ventricle. Choice D names a genuine but rare inherited disorder that presents in newborns, not in an adult with pancreatitis. If you see stiff, collapsing lungs, leads to ask whether surfactant was never made or has been inactivated. Which is the most likely diagnosis? A 46-year-old woman has episodic wheeze and cough. Baseline FEV1 over FVC is 0.62. After inhaled albuterol, FEV1 increases by 19% and by 340 ml. Rate the command. The most likely diagnosis. The obstruction is established by the ratio. What identifies the disease is what happens after the bronchodilator. Both asthma and COPD reduce the FEV1 over FVC ratio, so the ratio alone cannot separate them. Reversibility does. A rise in FEV1 of at least 12% and at least 200 ml after a bronchodilator defines significant reversibility. And that is the hallmark of ASD-HMA, where the obstruction is driven by bronchial smooth muscle constriction and inflammation that relax in response to a beta-2 agonist. COPD obstruction arises from destroyed alveolar walls and loss of elastic recoil, structural changes that cannot relax, so it shows little or no reversibility. Choice: a wrong. The correct answer is B. Choices C and E are excluded by the ratio before reversibility is even considered, which is a useful reminder of the reading order. Pulmonary fibrosis is restrictive and preserves or raises the ratio, and heart failure causes congestion rather than fixed airflow obstruction, although it can produce a wheeze, often called cardiac asthma. Whereas spirometry is equivocal in a patient with a suggestive history, a methacholine challenge demonstrating hyperresponsiveness supports asthma. If you see obstruction that improves markedly with a bronchodilator, leads to think asthma, not COPD. Which rhythm is present? An ECG shows a regular ventricular rhythm at 150 per minute. Between the QRS complexes, the baseline shows a continuous sawtooth pattern of atrial activity at approximately 300 per minute, best seen in the inferior leads, with no isoelectric interval. Read the command. Which rhythm? Two atrial arrhythmias dominate this differential, and they are separated by regularity and by the shape of the baseline. Atrial flutter is a single organized macro-reentrance circuit, usually in the right atrium, discharging near 300 per minute. Because the circuit is organized, the baseline shows a continuous sawtooth of flutter waves with no flat interval between them, and because the atrioventricular node conducts a fixed fraction, the ventricular response is regular-regular, most commonly 2:1, giving the characteristic rate near 150. Atrial fibrillation is the opposite on both counts. Chaotic, disorganized atrial activity produces an irregular fibrillatory baseline and an irregular ventricular response. Choice A wrong. The correct answer is D. A regular, narrow, complex tachycardia at almost exactly 150 should always raise flutter with 2:1 conduction, because the second flutter wave hides within the QRS or T wave and is easily missed. Vagal maneuvers or adenosine transiently increase the block and reveal the sawtooth. Choice B produces an irregular rhythm with at least 3 distinct P-wave morphologies, classically in severe COPD. Choice E would produce wide complexes rather than the narrow ones implied by organized atrioventricular conduction. If you see a regular tachycardia near 150 with the sawtooth baseline leads to think atrial flutter conducting 2:1. Which intervention produced this change? In a patient with heart failure, an intervention produces a shift of the entire Frank-Starling curve, UPWA, and leftward so that a greater stroke volume is generated at any given end, diastolic volume. Read the command. Which intervention produced the shift? The distinction between moving A along a curve and moving the curve itself is what this question is built on. Preload changes move the heart A along its existing curve, giving fluid increases end, diastolic volume, and therefore stroke volume, but the relationship between the two is unchanged, so the curve itself does not move. Only a change in contractility moves the whole curve. A positive inotrope, dobutamine, digoxin, or endogenous catecholamines shifts it up and left, generating more stroke volume for the same filling. Negative inotropes, ischemia, and acute beta blockade shifted down and right. Choices A and B change position on the curve rather than the curve itself. The correct answer is E. Choice D is the subtle one and rewards precision. Raising afterload does reduce stroke volume at any given preload, so on many representations it appears to depress the curve. But the underlying contractile state is unchanged, and the effect is better understood as the ventricle ejecting against greater resistance. In the failing heart, this matters therapeutically. Afterload reduction with vasodilators improves stroke volume substantially, which is precisely why these agents are central to heart failure management. If you see a Starling curve question leads to decide first whether the curve moved or the point on it moved, which is the most likely diagnosis. A 63-year-old man with poorly controlled hypertension has sudden severe chest pain radiating to the interscapular area. Blood pressure is 19.8 over 106 millimeters of mercury in the right arm and 152 over 84 millimeters of mercury in the left. ECG shows no ST elevation. A widened mediastinum is seen on chest radiography. Read the command. The most likely diagnosis. Chest pain with hypertension suggests a coronary event, and 3 findings here point somewhere else entirely. Aortic dissection begins as an intimal tear that lets blood into the media and propagate a false lumen. That false lumen can compress the origin of a branch vessel, most visibly the subclavian artery, producing the interarm blood pressure differential, and the expanded aorta produces the widened mediastinum. The pain is classically sudden, maximal at onset, tearing and radiating to the eye interscapular region, whereas ischemic pain builds over minutes and radiates to the arm or jaw. Hypertension is the dominant risk factor. The correct answer is C. The management point is one of the most testable in the chapter and is a genuine trap, anticoagulation, or thrombolysis. Entirely appropriate if this were a myocardial infarction, would be catastrophic in dissection. So the diagnosis must be excluded before treating an atypical chest pain as an infarct. Blood pressure is lowered with a beta blocker first to reduce the shear force, and only then with the vasodilator, since the vasodilator alone provokes reflex tachycardia and increases that shear force. If you see tearing chest pain with unequal arm pressures leads to think dissection before infarction. Which mechanism explains the increased digoxin toxicity? An 80-year-old woman on digoxin for heart failure is started on furosemide. 2 weeks later, she has nausea, confusion, and yellow-green visual halos. ECG shows a scooped ST segment and frequent ectopy. Potassium is 2.9 milliequivalents per liter. Read the command, the mechanism of increased toxicity. The drug interaction here is not pharmacokinetic but a direct competition at the target. Digoxin acts by inhibiting the sodium-potassium ATPase, and potassium competes with digoxin for the same binding site on that pump. When serum potassium falls, less potassium is available to compete, so more digoxin binds and the pharmacodynamic effect at any given serum concentration increases. That is why a patient can become toxic with the digoxin level in the therapeutic range, and why loop and diazide diuretics, which waste potassium, are the classic precipitants. Choice E states the relationship backwards, and choice C would reduce rather than increase toxicity. The correct answer is A. Because the interaction is competitive at the target rather than a matter of drug levels, the practical rule is that potassium must be monitored and repleted in every patient taking digoxin with a diuretic. Choices B and D describe plausible-sounding pharmacokinetic mechanisms that do not apply. Digoxin is minimally protein-bound and is cleared renally rather than hepatically, which is itself the reason renal impairment is another major precipitant of toxicity in older patients. If you see digoxin toxicity leads to check the potassium before questioning the dose. Which valve lesion is present? A 39-year-old woman who grew up abroad has exertional dyspnea and palpitations. There is a low-pitched diastolic rumble at the apex following an opening snap and a loud S1. The left atrium is markedly enlarged and she is in atrial fibrillation. Read the command, the valve lesion. The mitral lesions are separated by when in the cycle the murmur occurs and by the presence of an opening snap. A stenotic mitral valve obstructs filling, so its murmur occupies diastole, a low-pitched rumble at the apex, preceded by an opening snap as the thickened but still pliable leaflets are forced open. The same thickening makes S1 loud. Because the left atrium must generate higher pressure to fill the ventricle, it dilates progressively, which is why atrial fibrillation and left atrial thrombus with systemic embolism are characteristic complications. Rheumatic heart disease remains the dominant cause worldwide. Mitral regurgitation, by contrast, produces a hollow systolic murmur radiating to the axilla with no opening snap. Choice A. Wrong. The correct answer is D. The enlarging left atrium produces two compression signs that appear in vignettes as apparently unrelated complaints: dysbiasia from pressure on the esophagus lying immediately behind it, and hoarseness from stretching of the left recurrent laryngeal nerve, known as Ortner syndrome. Choices B and C are aortic lesions whose murmurs are heard at the base with different timing, and choice E produces a systolic murmur that increases with inspiration. If you see a diastolic rumble with an opening snap, leads to think rheumatic mitral stenosis. Which is the most likely diagnosis? A 34-year-old woman has cough and fatigue. Chest radiography shows bilateral hilar lymphadenopathy. Serum calcium is elevated, angiotensin-converting enzyme is elevated, and a tuberculin skin test is negative. Biopsy shows non-casein granulomas. Read the command. The most likely diagnosis. Granulomas narrow the field immediately, and one histologic adjective decides between the two leading candidates. Granulomas divide into caseating and non-caseating, and that single distinction carries most of the diagnostic weight. Caseating granulomas with central necrosis indicate mycobacterial or fungal infection. Non-caseating granulomas indicate sarcoidosis, and its presentation here is complete bilateral hilar lymphadenopathy in a young adult, an elevated angiotensin-converting enzyme, and hypercalcemia. The negative tuberculin test reflects the cutaneous anergy typical of sarcoidosis and argues further against tuberculosis. Choice A wrong. The correct answer is B. The hypercalcemia has a mechanism worth knowing because it is independently testable. The activated macrophages within sarcoid granulomas express 1 alpha hydroxylase, converting 25 hydroxyvitamin D to its active form outside normal parathyroid control, so calcium rises with a suppressed parathyroid hormone. Choice C typically produces asymmetric adenopathy with Reed-Sternberg cells and B symptoms, and choice D would follow a clear occupational exposure with upper zone nodules and eggshell calcification. If you see non-caseating granulomas with bilateral hilar nodes, leads to think sarcoidosis and check the calcium. Which molecular defect explains these findings? A 19-year-old man has recurrent Pseudomonas pneumonia. Chronic productive cough with dilated thick-walled airways on CT, steatorrhea, and infertility with absent vas deferens. Sweat chloride is 92 milliequivalents per liter. Read the command. The molecular defect. Several diseases give bronchiectasis and infertility. The sweat chloride and the pancreatic involvement identify 1. Cystic fibrosis results from mutation of the CFTR gene, most often the phenylalanine 508 deletion, which encodes a chloride channel. Defective chloride and consequent water transport leaves secretions thick and dehydrated throughout the body. In the airways, this impairs mucociliary clearance and produces chronic infection, bronchiectasis, and eventual Pseudomonas colonization. In the pancreas, it obstructs ducts, causing exocrine, insufficiency, and Steter, with fat-soluble vitamin deficiency. And in the reproductive tract, it causes coimedoral, bilateral, absence of the vas deferens with obstructive infertility. In sweat glands, the channel normally reabsorbs chloride, so failure leaves sweat salty. The diagnostic test. The correct answer is C. Choice A is the closest competitor and shares two features with cystic fibrosis. Primary ciliary dyskinesia also produces bronchiectasis, chronic sinusitis, and infertility. It is separated by a normal sweat chloride, by preserved pancreatic function, and by situs inversus in roughly half of patients, the triad known as Cartagener syndrome, in which infertility results from immotile sperm rather than from an absent duct. Choice B causes emphysema rather than bronchiectasis and spares the pancreas. If you see bronchiectasis with steatorrhea and infertility, leads to think CFTR and send the sweat chloride. Which is the most likely diagnosis? A 57-year-old man with alcohol use disorder and poor dentition has 2 weeks of fever and foul-smelling sputum. CT shows a thick-walled cavity with an air fluid level within the lung parenchyma of the right lower lobe. There is no pleural fluid. Read the command, the most likely diagnosis. Two infected collections look alike on imaging, and the discriminator is anatomic. Which compartment holds the fluid? A lung abscess is a necrotic cavity within the lung parenchyma itself, typically following aspiration, which is why alcohol use, seizures, stroke, and poor dentition are the standard risk factors, and why anaerobes such as Peptostreptococcus, Prevotella, and Fusobacterium produce the characteristically full, smelling sputum. An empyema is pus in the pleural space outside the lung, and its absence is stated explicitly here. The distinction determines management. An abscess is usually treated with prolonged antibiotics, whereas an empyema requires drainage. Choice A wrong. The correct answer is E. The location follows gravity and bronchial anatomy, which is why the right lower lobe is named here. The right main bronchus is wider and more vertical, so aspirated material preferentially enters it, reaching the posterior segment of the right UPPER lobe if the patient was recumbent, and the superior segment of the right lower lobe if upright. Choice B deserves consideration in any cavitary lesion in a smoker, but the acute febrile course with foul sputum and clear risk factors points to infection. If you see a cavity with an air fluid level, leads to decide whether it lies inside the lung or in the pleural space. How should this effusion be classified, and what does it imply? A pleural effusion is sampled. Pleural protein divided by serum protein is 0.62. Pleural lactate dehydrogenase divided by serum lactate dehydrogenase is 0.71. Pleural lactate dehydrogenase is above 2/3 of the upper limit of the serum reference range. Read the command, the classification, and its implication. Light's criteria are a threshold test, and meeting any one of them settles the category. Light's criteria classify an effusion as an exudate if any one of three thresholds is met: a pleural to serum protein ratio above 0.5, a pleural to serum LDH ratio above 0.6, or a pleural LDH exceeding 2/3 of the upper limit of the serum reference range. All three are exceeded here, so this is unambiguously an exudate. An exudate means the pleural membrane itself has become leaky through inflammation, infection, or malignancy. A transudate results instead from altered Starling forces across an intact membrane, so choices B and C misclassify the fluid. The correct answer is A. Choice D is internally contradictory and worth naming as such. Congestive heart failure raises hydrostatic pressure across an intact pleura and therefore produces a transudate, not an exudate. Although a patient diuresed vigorously before sampling can produce borderline values that mislead. The classification matters because it directs the next step entirely. A transudate is managed by treating the underlying heart, liver, or kidney disease, whereas an exudate demands a search for infection or malignancy with cytology and culture. If you see any single light criterion exceeded, leads to call it an exudate and look for a cause in the pleura. Which is the most likely diagnosis? A 26-year-old man given a topical anesthetic before bronchoscopy becomes cyanotic. Pulse oximetry reads 85% and does not improve on 100% oxygen. Arterial PaO2 is 1004 millimeters of mercury. The blood appears chocolate brown and does not redden on exposure to air. Read the command, the most likely diagnosis. Cyanosis with a normal PaO2 narrows the field, and the color of the blood settles it. Certain oxidizing agents, benzocaine and other topical anesthetics, dapsone, nitrites, convert hemoglobin ion from the ferrous to the ferric state, producing methemoglobin. Ferrohemoglobin cannot bind oxygen, and it left shifts the remaining normal subunits so they release oxygen poorly. Because the lungs are normal, the dissolved PaO2 stays normal, but functional carriage collapses. The visual signature is CO choco, brown blood that does not turn red on exposure to air, and the saturation reading plateaus near 85% and will not rise with supplemental oxygen. Treatment is methylene blue. The correct answer is B. Carbon monoxide is the instructive contrast because it also produces a normal PaO2 with impaired carriage, yet it fails on every other feature. It makes the blood and skin cherry, red rather than brown, and standard pulse oximetry reads falsely, normal because it cannot distinguish carboxyhemoglobin from oxyhemoglobin, rather than reading a fixed 85%. One caution completes the picture. Methylene blue requires NADPH to work and can precipitate hemolysis in G6PD deficiency, where ascorbic acid is used instead. If you see cyanosis with a normal pale in brown blood, leads to think methemoglobinemia and give methylene blue. Which is the most likely diagnosis? A 68-year-old man with severe COPD has ankle edema, distended neck veins, and a tender enlarged liver. There are no pulmonary crackles and no orthopnea. Echocardiography shows a dilated, hypertrophied right ventricle with a normal left ventricle. Read the command, the most likely diagnosis. Right and left heart failure produce congestion in different places, and here the lungs are conspicuously clear. The rule is simple and reliable. The failing ventricle backs up into whatever drains into it. A left heart failure backs up into the pulmonary veins, producing crackles, orthopnea, and paroxysmal nocturnal dyspnea. Right hip heart failure backs up into the systemic veins, producing distended neck veins, hepatic congestion with tenderness, and peripheral edema. Exactly this picture. When right heart failure arises from lung disease rather than from left heart failure, it is called core pulmonal. Chronic hypoxia drives hypoxic pulmonary vasoconstriction, pulmonary vascular resistance rises, and the right ventricle hypertrophies and eventually fails. A normal left ventricle excludes choice. The correct answer is D. The nomenclature contains a trap worth stating plainly. Although core pulmonale is right heart failure from lung disease, the single most common cause of right heart failure overall is LEFT heart failure, and by convention that is not called core pulmonale. A normal left ventricle is therefore part of the definition, not an incidental finding. Choices B and E would produce systemic congestion too, but with a small or normal right ventricle rather than the hypertrophied one described, and each has its own distinguishing signs. If you see systemic congestion with clear lungs in chronic lung disease, leads to think core pulmonale. 50 questions done. Before you go, 5 discriminators worth carrying out of this session. Each of those separated 2 conditions that looked identical until one number moved. That is the skill this series trains, and it is the skill the exam actually measures. Next in the series, renal, acid base, and electrolytes. Same format, same discipline, step logic. Learn how to think, not memorize.